Thank you very much for inviting me for present as a chairperson of this important session, and I have also a presentation. But aim of the presentation of my presentation is to make aware of the recent development of the treatment of acute lymphoblastic leukemia in children, and also the position we hold in our country, that are we remain too much back in the recent trend of treatment or not. So as in as a hematologist, of all of we aware of the recent development, I hope. So acute lymphoblastic leukemia is the most common childhood cancer, and it accounts for 26% of the malignancies. And once it is deadly disease in 60s, now 5-year survival rate exceeds 90% in developed countries. And 5-year overall survival once upon 57% in 1970 came up to 96% in the most recent studies. And next we see how it looks like. This is the overall survival of pediatric patient with acute lymphoblastic leukemia treated in St. Jude's total therapy studies. Here you see the important one is from 2000. There is a total 15 and 16 studies. There is from 2007 and onward, the overall survival remains in the flat line. So what does it indicate? It indicates that we already got our the management, the medications. We received we got the medication, but here now this challenge is how to overcome this toxicity, and now it is at a plateau. There is 10% patient, or 15 to 10% patients are not curing with this current treatment, the treatment that is using. So I make this annotation, like Rome was not built in a day, they worked on it every single day. So the people who are engaging in the treatment of leukemia, they are also working on every day, and they are changing minds, they are searching the new agents, new therapy, and there is that with that history is made. So you see the history in the 90s. Different leukemia groups were formed with their help of the physician treating the leukemia. And in 60s, in this, some new drugs develops in the 60s, and there is an important one is vincristine, asparaginase, as well as other drugs like cytoxan and daunorubicin, etc. And in 70s, the total therapy developed, and supportive care like plasma, platelet transfusion, and other supportive care also developed. In 80s, survival with this method of combination of treatment, survival reached 50%. And in 90s, adoption of the, by BFM, the risk classification, the risk adapted therapy, and here also bone marrow transplantation also developed. And after then, during this century, during these decades, the molecular the biology techniques and individualized the chemotherapeutic dosing also developed. And the first decades of the 21st century, this is the golden period for the development of the treatment of acute lymphoblastic leukemia, by incorporating tyrosine kinase for the treatment of Philadelphia chromosome positive ALL, which was the risk factor for the developing relapse, and using long-acting pegylated asparaginase, and approval of nelarabine, and with the recurring T-cell ALL. And one of the important issues also, the young adult with ALL treated with pediatric protocols have a better outcome. These are the pictorial scenario. This shortage of time, I will not go for in details. We see some biologic advantages, and I will speak on therapeutic advancement. The different age, you see the every steps in every year or few years interval, there is some improvement, starting and up to the in 2019 the initiation of the imatinib. So if we see this current status of treatment is the starting from combination chemotherapy, then radiotherapy, after then initiation incorporation of the tyrosine kinase, genus kinase inhibitor, and recently the introduction of the monoclonal antibodies, the immunotherapy. Here is some important drugs effect on the on acute leukemia. I'll not go for details. In this slide, I'd like to show the in the different study group shows in they are working in different places, but their fiber survival and event free survival remains 79 to 76 to 80% in different protocol. So this advantage actually largely depends on the four things, that immunophenotyping, molecular diagnosis, cytogenetics, and MRD studies. So by immunophenotyping, we just helps in classify the acute lymphoblastic leukemia in different B cell, A cell, T cell leukemia, as well as it also helps in pinpointing the diagnosis. And also nowadays it also helps in different further subclassification of the leukemia, the T cell, ETP, ETP leukemia, ETP ALL, like this. And molecular diagnosis, there is cytogenetics also helps in the classification of the acute lymphoblastic leukemia, but also earlier before starting chemotherapy, it helps in identifying the disease. There is good cytogenetics, high risk cytogenetics, like this. And another important one is minimal residual disease. This has revolutionized the treatment protocol and treatment strategy and treatment goal of the acute lymphoblastic leukemia in children. And MRD has got a strong contributor for overall outcome in acute lymphoblastic leukemia. So how do we apply this knowledge to our clinical practice? You just see we are classifying the disease by immunophenotyping, cytogenetics, and in different different risk group. And based on this risk group, we are starting therapy during induction. And that is low risk group, we are just practicing fewer medicine, but higher risk we apply the more medicine. So and lately the immunotherapies in pediatric ALL, this also shows the way how where would you fail in other protocol in achieving this 90% remission, but where the relapse and recurrence of the disease occurs. But the immunotherapy has shown us the way how to overcome this risk group treatment by applying the immunotherapies, monoclonal antibodies. And we have at hand the anti-CD2 antibody and antibody drug conjugates like this, and anti-CD20 antibodies are like rituximab. You are using rituximab in our practice. So I'll skipping these slides. Now I'd like to share our experience that where we stand in Bangladesh in treating the pediatric acute lymphoblastic leukemia. You see, use of MRC 11 is single protocol used for in earlier use. By adoption vehicle 2003 protocol, we adopted 2007, We have started immunophenotype in that period. MRD, we started MRD in 2021, and cytogenetics in 2023. In 2022, only 2 centers offered the treatment for ALL, but right now we have 15 centers in Bangladesh run by pediatric hematologists now giving treatment of cancer patients. And I just show you this once the difference between this nowadays right today and in the earlier year. In 2002 and 2024, only 2 center and more than 15 center. The enrolled patient at that time was only 250, but right now the last year we we recorded more than 2500 patients. Although we are having the more than 6,000 patients, but still we are lagging behind because of our involvement. And we are using at that time the only MRC 10, MRC 820, 841 protocol. uh, but now right now we are using UCAL 2019 guideline, the latest guideline we are using in the Europe as well. So one patient who have started the treatment in our centers, they will be able to avail the treatment the same protocol if they shifted to UK. So right now, at that time hematologist was 4 to 5 right now, and at this moment we have more than 60 registry. There is no registry, but survivor registries. We are doing the survivor registry, and right now in our center 400, and if we accumulate this survivors from all these centers, likely it will go more than 1,000, right? Uh, okay. So uh, back in 39 years earlier, only established one pediatric hematology and oncology department with the acute lymphoblastic leukemia survival not more than 3 months. It is referred by Professor M. Mannan, the founder of the pediatric hematology. But with the continuous reports, now overall survival becomes 40 to 51% right now. Our success is commendable, but failure is not excusable. ALA relapse is one of the weak point of the treatment. So, what is our challenge? Challenge is delay in diagnosis and referral. Dropout. There are many dropout here. Dropout starting from before starting treatment and after in ongoing treatment. NGS is our next issue is NGS critical care. BMT center should be is our necessity right now to treat the relapse and refractory patients. And immunotherapy and CAR-T is our primary goal. So woods are lovely, dark and deep, and but I have promises to keep and miles to go before I sleep. Thank you very much. Thank you.